All right, good afternoon, everybody, and welcome to the Classical Hematology Review of the American Society of Hematology meeting in 2022. Thank you for joining us. My name is Robert Bona. I work here at Yale in the section of hematology, and I'm very excited and happy to introduce our three speakers today. I will be brief with their introductions since I don't want to take away time from the important things that they're going to talk with us about. Layla Van Doren will begin our discussion. Layla joined, all three of our faculty actually have joined the classical hematology program at Yale this academic year. And Layla joined us from Columbia, and she brings a wealth of experience and knowledge with her. And at Yale, she is going to be focusing on sickle cell diseases and iron disorders of iron hemostasis, in particular, iron homeostasis, in particular in the area of women's health. Dr. Goshua, a Yale Fellow and graduate of the Harvard Public School of Health, is focusing his research work here at Yale on decision science analysis and hematologic disorders. And Anish Sharda joined us from the Beth Israel Deaconess Medical Center. He has a active laboratory program looking at endothelial function and in particular the expression and secretion of von Willebrand factor. So again, I'm very excited to have them present their work to us today, or their review of some of the ASH top hot abstracts. And please put your questions in the chat room or in the Q&A, and we'll get to those at the end of the session. Each of our presenters will present for about 15 minutes, and then we'll take questions at the end. So without further ado, Dr. Van Doren, would you like to get us started?
Sure. I'm going to share my screen. And there we go. Okay. These are my disclosures. All right. These are the two abstracts that I'm going to be discussing today. So we'll just jump into it. The first abstract is focused on inherited thrombophilia in pregnancy, anticoagulation, and thrombophilia testing. So I wanted to start out with a case first. It's a 38-year-old patient who presents for evaluation at 8 weeks gestation. She has a history of 3 miscarriages in the first trimester. Antiphospholipid antibody testing was previously negative, but she was found to be positive for factor V Leiden heterozygous mutation. And the question is, would you recommend anticoagulation during pregnancy for this patient to increase her chance of live birth? So the background is that studies have shown an association between recurrent miscarriage and inherited thrombophilia. For women with APLS, we know that the use of heparin or low molecular weight heparin combined with low-dose aspirin is an effective treatment for recurrent miscarriage. And the thought about the role of thrombophilia in recurrent miscarriage is that it can be explained partially by the concept of thrombosis of the microvasculature of the placenta. And so it is thought that anticoagulant therapy might reduce miscarriages and adverse pregnancy outcomes in patients with inherited thrombophilia as well. However, there's a lack of solid evidence for this practice. And so in 2010, a study was published, a LIFE study, that was a randomized placebo-controlled study investigating whether aspirin plus low molecular weight heparin or aspirin alone combined compared to placebo would improve the live birth rate among 364 women. So there were 3 different arms. And what this study showed was that there was no difference in the live birth rates between the study groups with the relative risk of 1.03. And in patient-specific thrombophilia, there was also no difference, although the number of patients in the study with an inherited thrombophilia was very low. And so which brings us to the A-Life 2 study, the first abstract, which was a late-breaking abstract at ASH in December 2022, and it was 10 years in the making. So the objective of the A-Life 2 study was specifically to evaluate the efficacy of low molecular weight heparin in women with an inherited thrombophilia with recurrent miscarriage. And so the way the study was designed is that patients who had a history of 2 or more miscarriages with an inherited thrombophilia, no more than 7 weeks gestational age, could be enrolled. They were randomized 1-to-1 to receive either a low molecular weight heparin, and those are the different ones that were used in the study, plus the standard of pregnancy care or standard of pregnancy care alone. The outcomes was, the primary efficacy outcome was the live birth rate. Secondary efficacy was miscarriage or adverse obstetric outcomes, and then safety was looked at as well. And so these are the characteristics of the patients. The mean age was 33, and the majority of patients actually had 3 or more miscarriages. The most common inherited thrombophilia was the factor V Leiden heterozygous, followed by prothrombin gene mutation heterozygous, protein S deficiency, and then a mix of antithrombin, combined thrombophilias, and then protein C deficiency. And the outcome of the study was that there was no difference between the standard of care and low molecular weight heparin plus standard of care in the live birth rate. So the odds ratio was 1.04. When this was adjusted for age, so less than or greater than or equal to 36 years old, the number of miscarriages or the center, so if a patient was treated at a tertiary center or a non-tertiary center, or by country, UK versus the Netherlands, there was still no difference between the live birth rate in the different arms. In terms of the differences in adverse effects, there were more adverse effects in patients receiving low molecular weight heparin, such as easy bruising, skin reactions at injection site, and minor bleeding. And so the conclusions of this study was that low molecular weight heparin did not result in a higher live birth rate in women who had greater than or equal to 2 pregnancy losses and confirmed inherited thrombophilia. And the recommendation is to not use low molecular weight heparin in women with recurrent pregnancy loss and confirmed inherited thrombophilias to prevent pregnancy loss. And so this also speaks to not against the routine testing for inherited thrombophilia in women with recurrent pregnancy loss. So that is the first abstract. The second abstract will focus on sickle cell disease, urea, and diminished ovarian reserve. So second case, a patient comes to you, 12 years old. She has a history of avascular necrosis and very rare vaso-occlusive crises. She presents for initial visit. During the visit, you discuss the importance of hydroxyurea as a disease-modifying therapy. She notes that her previous provider told her she does not require hydroxyurea therapy due to infrequent vaso-occlusive crises. But furthermore, of most concern for her is a Facebook group that she's a part of recommends not taking it for those who desire to have children in the future, as it leads to infertility. So there is quite a bit of evidence for hydroxyurea and fertility in males. We know that it leads to lower sperm counts, which improves with cessation of hydroxyurea, but we don't have a lot of data available for the use of hydroxyurea and diminished ovarian reserve in female patients with sickle cell disease. And so from the evidence that we do have, we do know that patients with sickle cell disease have a higher rate of diminished ovarian reserve compared to those who are age, race, and sex matched to patients with sickle cell disease. There's much more of a sharper trajectory of decline of diminished ovarian reserve. And the thought is that this is, and it was a theory, again, it had not previously been proven, the thought is that this is related to hemolysis and anemia, vaso-occlusion, basically any organ that can be affected by sickle cell disease, which is every organ in the body, the ovaries included, this can all lead to diminished ovarian reserve. And one thing that we don't know is hydroxyurea, is it a friend or a foe? So we know that hydroxyurea causes reduction in disease severity. So in theory, it should be preventing this accelerated age-related loss of eggs. But does it actually also contribute to the accelerated age-related loss of eggs? And that is the question that we don't know the answer to. And so this study was actually, this is a background study. So this was done from the multi-center study of hydroxyurea, and it was the pivotal trial that showed the benefits of hydroxyurea in patients to prevent organ damage. And what this shows here is that you can see at every age level, starting from 20 to 25, we see that there's an age-associated decline in the AMH level, which is a marker of diminished ovarian reserve. When the AMH level is less than 1.1 nanograms per ml, this contributes to the definition of diminished ovarian reserve. The dark lines here the median age control match AMH levels. And the gray boxes here, these are patients with sickle cell. So we see even at age 20 to 25 years old, there is lower AMH levels compared to the controls. And it's not until age 40 to 46 where we see that the controls as well as patients with sickle cell disease both have AMH levels of less than 1.1. Okay. And so what do we know? We know that patients with sickle cell have higher rates of diminished ovarian reserve, at least starting 25 to 30 years old. The relationship between diminished ovarian reserve and pregnancy outcomes and live births in sickle cell does require further study, because that is a question we don't have an answer to. But the data regarding gonatotoxicity in women with sickle cell disease who are taking hydroxyurea is limited. And it's thought that hydroxyurea use might be a surrogate for disease severity rather than the hydroxyurea itself causing diminished ovarian reserve. And so this is the next abstract, and their study aimed to assess this. Does hydroxyurea and does vaso-occlusive crises cause diminished ovarian follicle density in girls and young females with sickle cell disease? And so this study, it was designed, 88 patients with hemoglobin SS genotype underwent ovarian tissue cryopreservation prior to stem cell transplant. Ovarian tissue was evaluated histologically by 2 independent investigators, and the primary outcome was ovarian follicle density. And here are the characteristics. So most of the patients had not reached puberty. 45% were treated with hydroxyurea with a median dose of 23 milligrams per kilogram. And the vast majority of patients did report vaso-occlusive crisis. Of those patients who had vaso-occlusive crisis, 49% were on hydroxyurea. 94% of patients received packed red blood cell transfusion at some point, with the median applied units of 22. And so the outcome of the study showed that the follicle density was similar in the hydroxyurea group compared to those without hydroxyurea exposure. But for the first time, a study did show that the follicle density was significantly higher in patients who did not have vaso-occlusive crisis. And so this suggests that it's actually the disease itself rather than hydroxyurea that is leading to diminished ovarian reserve. And so the conclusions of this study, as I said, were that hydroxyurea exposure did not appear to reduce cortical follicle density in females with sickle cell disease. And for the first time, the study could show an influence of VOC on ovarian follicle density, possibly related to reduced blood flow and all the effects of sickle cell disease. What we don't know is what the ovarian follicle density would look like in a patient who has been on hydroxyurea for a much longer duration, because the median age of the patients in this study was 9 years old. And the evidence that we have for diminished ovarian reserve in patients with sickle cell really starts at age between 20 and 25, that multi-center study of hydroxyurea that I showed you previously. And lastly, longitudinal data are needed to evaluate if genotype and severity of disease accelerate diminished ovarian reserve. Thank you, and that's it.
It is a pleasure to follow Dr. Van Doren, and so I will take over the screen sharing. Beautiful. Good afternoon, everyone. Thank you for joining. My name is George Goshua. I am an assistant professor of medicine and hematology here at Yale, and I'm the PI for a quantitative decision science lab. So without further ado, let's talk about 3 hard-hitting abstracts. I have no disclosures. The first, we're going to go and talk through cold agglutinin disease and immune thrombocytopenia. We're going to start with all of these, by the way, are orals. One of them is a plenary, as I'll point out in the next talk. And the last talk will be focused on a phenomenal study actually done by a trainee from the Cleveland Clinic. So talking about patient-reported outcomes first, and sutimlimab use in our patients with cold agglutinin disease. And so this is the schematic for cadenza. And this is a trial that focused on transfusion-independent individuals with cold agglutinin disease. You can see Part A and Part B. Part A has been reported on previously. At this year's ASH, Alexandra Roth and colleagues reported on Part B, and so that is what I'll focus on. But for anchoring, Part A was a double-blind period of randomization to sutimlimab versus placebo. You see that there's a screening observation period there of 6 weeks leading into that study. And Part B was then the continuation of the open label phase component of patients who are on sutimlimab, and patients who are on placebo going to sutimlimab. So in the open label extension Part B, all of those patients who completed Part A were eligible then to receive biweekly doses. And this was weight-based, as you can see in front of you. What we'll focus on the next slide will be the patient-reported outcome endpoints, and there are 5 of them. And so the objective here, again, is to look at transfusion-independent patients. This is cadenza trial, as opposed to transfusion-dependent cold agglutinin disease patients. So that would be cardinal. And the follow-up here is a median treatment over 99 weeks. And the patient-reported outcomes are, you can see them in front of you here. The FACIT fatigue, the PGIS, the PGIC, the 12-item SF12. And I noted, for specific reasons that you'll see on the next slide, what that includes, both physical and mental component scores. And finally, the Euroqual visual analog scale. And here are the baselines and the patient sample sizes and the mean effects. And in the right column here, I put for you what the investigators reported as clinically important changes that were derived in prior studies. So we can actually interpret what is clinically meaningful or potentially clinically meaningful. So the mean age of these patients was 67. 80% of them were women. And you can see the FACIT fatigue score with an improvement of 8.8 right in the middle there, with a standard error of 2.1. You'll note a reported clinically important change, which is available here, is more than 5. You have to think about that in the context of the standard error. Now, the SF12, the physical and the mental cognitive scores as well, hit above the reported clinically important changes with sutimlimab use, and you'll see an added about 4.9 points for the physical component, 4.0 points for the mental component. And the last piece within the rows, you see the EQ visual analog score scale again, an added improvement there, but there is not a study that has derived and validated a reported clinically important change here. And so that's why I put that as a non-applicable. Now, if you look at PGIS and PGIC, you can see too that for the PGIS, 31%, there was a 31% improvement in the proportion of patients reporting no or mild fatigue. So more patients by the conclusion of the study reported no or mild fatigue. And the delta there was from about mid-40s to mid-70s percentage-wise. And finally, the PGIC, by the end of the study, 71 of the patients who were reporting a positive change from the baseline from where they had started from. So take home, so the cadenza Part B, PRO data, it appears that sutimlimab can demonstrate benefits that are associated with its use, specifically on fatigue and overall quality of life. The benefits appear to maintain for more than 1 year. As I mentioned, median follow-up was 99 weeks. And this is important, patients previously treated with placebo did demonstrate a brisk PRO improvement in Part B. So these are the patients who went from placebo to sutimlimab. So they are able to catch up to the patients who had been on sutimlimab before. Moving to a plenary, this is Efgartigimod in ITP. Efgartigimod is an IgG1 Fc fragment and a natural ligand for the neonatal Fc receptor. It's engineered to competitively bind to FcRn with a high affinity and prevent the recycling of endogenous IgG, but it doesn't affect albumin. This drug has been approved in myasthenia gravis, and here I present to you the results from ADVANCE-4, which is a phase 3 multicenter double-blind placebo-controlled RCT in patients with immune thrombocytopenia. Generally speaking, when we think about pathogenic autoantibodies in ITP, we think about increased platelet clearance as one of the mechanisms inhibiting platelet production and impacting platelet function. You see all of those listed in the schematic to the left. And then on the right, the schematic for the recycling of your endogenous IgG and where efgartigimod is acting. Now, for this RCT, You had to have been an adult, so at least 18 years of age, and to have chronic or persistent ITP. And as a reminder, chronic ITP is ITP of duration of 12 months or more. Persistent is 3 to 12 months. You had to have 2 platelet counts of less than 30,000 during the screening period. And the screening period lasted 2 weeks for this trial. And you had to have been on at least 2 prior ITP treatments or 1 prior treatment and 1 concurrent treatment. Those are the eligibility criteria. An important point for this trial that's not listed on the slide because it wasn't an eligibility criteria, but once the trial started, these patients needed to be maintained on the same dosing of whatever they were on previously for their ITP without dose escalations. So the treatment period was 24 weeks, and patients were randomized 2-to-1 to Efgartigimod 10 milligrams per kilogram intravenously versus placebo. And there was a period, as you can see in front of you here, where you could have dose adjustments of Efgartigimod. At the end of the trial, as we'll talk about, there's a follow-up period, and more than 90% went on to enroll in the open label extension called Advance Plus, that is in its early phases now. These are the baseline characteristics for these patients. You can see that they match up reasonably well. In particular, I'll point out the WHO bleeding scores, pretty similar across the board. Patients with 3 or more prior ITP therapies, patients that we technically think of as quote unquote refractory. That's how the trial referred to them as well. And that's about 6 to 7 out of 10 patients in both arms. And the concurrent ITP therapy types at baseline being utilized, steroids, TPORAs, and other immune suppressants, all reasonably nicely matched. And so here in this case, we can see that this random allocation has probably served its purpose of controlling for confounding. The endpoints here, here's the primary endpoint and also key secondary endpoints. All to say that all platelet-specific secondary endpoints were met. The primary endpoint was the proportion of patients with a sustained count response. And as typical in ITP literature, this was defined as a platelet count of 50,000 or more. And in this case, on at least 4 out of 6 clinic visits during the conclusion of this period, in this case, weeks 19 through 24, of course, in the absence of ITP flares. And then key secondary endpoints include cumulative weeks of disease control, so just the number of weeks of disease control, something called sustained platelet count response, and the durable sustained platelet count response, which is just extending that risk exposure period out to week 17. And so there's a significance on the platelet count in all of these. The take-homes from this plenary abstract was that lowering total IgG levels by targeting the neonatal Fc receptor appears to demonstrate statistically significant improvements in primary and secondary platelet endpoints. The drug also appears to be well tolerated without new safety signals. I did not have an opportunity to include that here, but most adverse events were reported as, quote, mild to moderate. And finally, the open label extension period is ongoing currently. Now, to wrap up this little portion with a third abstract from the Cleveland Clinic of 300 plus consecutive patients treated with splenectomy for a variety of different immune cytopenias. So the investigators here wanted to identify whether they could isolate risk factors that could potentially predict response to splenectomy in adult patients with immune cytopenias. On the right, you see a schematic of total splenectomy cases that they reviewed over the course of 20 years, from 2000 to 2020. And here you had 1,800 patients. There was a bunch of patients excluded as they were trying to hone in on cytopenias, and then ultimately on immune cytopenias. And at the very bottom, I circled for you in red, you can see what the diagnoses were that they considered: ITP, autoimmune hemolytic anemia, Evans syndrome, and autoimmune neutropenia. In general, this was a retrospective study, 339 patients, and the majority were ITP and autoimmune hemolytic anemia. The results are a little bit remarkable, even for the fact that this is a retrospective study. And here you can see ITP, autoimmune hemolytic anemia, and autoimmune neutropenia at the very least being presented in simple pie charts for having complete versus partial versus no responses to splenectomy. And at the bottom, you actually also see how fast those responses occurred in weeks. The overall response for all patients was 74%, complete response rate of 86%, and a partial response of 14% in these patients. But Perhaps the bigger take-home point was the following. In 1 out of 5 cases, there was a discordant diagnosis from pre to post-operation. On the left, in the left column, you see the splenectomy indication. In the middle, you see what the actual post-operative pathologic diagnosis was and the frequency of this occurring. In total, to be exact, it was 19%. So 19% of patients were discordant from pre to post-operative diagnosis. Again, in these 300 plus consecutively treated patients over the course of 2000 to 2020, 20 years in the Cleveland Clinic. And to wrap up with one final take home is the investigators did try to isolate the risk factors that could predict response versus not predict response. And these are being parsed out further, as I understand, in the actual manuscript that's being written up and probably will be published in the next 6 to 12 months. But the big take home points here, most of these are crossing your odds ratio of 1, but you'll see that young age, in particular age less than 40 years, seem to predict for a response to splenectomy, as well as primary ITP also seem to predict for a favorable response to splenectomy. On the converse side of it, requiring multiple therapies predicted for poor response to splenectomy. So take homes from this study is that splenectomy remains a valuable option, specifically in patients whose values and preferences align with surgery. And there's a surprisingly high proportion, 1 out of 5, that had an added value of the diagnostic component in their course. And so with that, I want to say thank you, and I'm going to transition over to Dr. Sharda.
Thank you, George. I have nothing to disclose as well. I will mostly be concentrating on some abstracts, interesting abstracts in the thrombosis realm, and mostly cancer-associated thrombosis. So the first one is the Catheter 3 study, which was a prospective study of apixaban for central venous catheter-associated upper extremity venous thromboembolism in cancer patients. This comes from at least 3 centers in Canada. So this was a multi-center prospective cohort study in patients with CVC-associated upper extremity DVT. They were treated with a low molecular weight heparin, dalteparin in their case, for 7 days, followed by a full dose of apixaban for 11 weeks. And the patients were followed for at least 12 weeks. The inclusion criteria was all adults with active malignancy and clinically significant, that is symptomatic upper extremity DVT in association with a CVC. And the main exclusion criteria were patients with active bleeding or platelets less than 75 or a need for dual antiplatelet therapy, as well as most of the patients with hematologic malignancies or planned for stem cell transplant, as well as pulmonary embolism only with hemodynamic instability. The primary outcome was catheter survival at 3 months, and the secondary outcomes were any types of symptomatic recurrent venous thromboembolism, as well as bleeding, both major as well as clinically relevant non-major bleeds, and death from any causes. So here on the patient's demographics here, there are 70 patients from 3 centers. Majority were female, about 60%, median age 62. The diagnostic modality used in most patients were Doppler ultrasounds. And as you can see, these are symptomatic events. So most 75% of the patients actually have proximal upper extremity DVT involving subclavian, at least subclavian veins. And this is perhaps slightly different from our practice. So about 80% of the patients, so these were mostly outpatient patients being treated outpatients, and about 80% of them had PICS, and only 20% had portocath. And as you can see, the type of cancer, about a third were breast and a third were colon, and the remaining were others. So coming to the primary outcome, so catheter survival. So at 12 weeks, 40 patients had, so which is about 57-60%, had catheters still present and functioning. But if you can see the reason for removal, actually most of the patients who had it removed was because of end of the therapeutic need, which is about 21 patients or 30%, and then a minor proportion of the patients with other reasons, which is infection, or 2 patients died, and there were no recurrent events. And so if you consider or exclude the end of therapeutic need, the catheter survival was almost 100% with apixaban therapy. The safety outcomes, only 1 patient had a recurrent DVT in the same arm. And even in this patient, the line was not removed and was functional. There were 12 bleeds, 6 major and 6 minor bleeds, and most happened within the first 2 months of treatment. There were 2 deaths, and they were both delayed and cancer related. Study limitations, of course, it's a single arm, and most of the patients were outpatients, and so perhaps not as ill, and with a limited follow-up. But I guess for our practice, many of these, or most of these patients, actually had PICs, outpatient, as compared to portocaths. So the conclusions were that the apixaban showed promise in treating central venous catheter-associated upper extremity DVT, and the observed bleeding rates were lower than as previously described with rivaroxaban. And so here are the other 2 studies done previously by the same group. So the first one was the catheter study, which was low molecular weight heparin followed by vitamin K antagonists. And then the more recent one was a catheter 2, which was rivaroxaban without a lead-in with the low molecular weight heparin. And here, as you can see, there are a lot more bleeds. And then the current one is the dolteperin followed by apixaban with perhaps with less bleeds. But I think the most important point is that in most of these patients, despite proximal and symptomatic upper extremity DVTs, the lines were not removed and were not associated with infusion failure, and the lines were able to be saved with anticoagulation. So coming to the second one, which is abstract number 519, and the title of the abstract is Early Dynamics of C-reactive protein to Predict Risk of Venous Thromboembolism in Patients with Cancer Treated with Immune Checkpoint Inhibitors. And this comes from Austria, Vienna, Austria. So just to be quick, venous thromboembolism is being recognized as a major complication of immune checkpoint inhibitor therapy. The rates have been described as high as 25%, but the prothrombotic effect of these immune checkpoint inhibitors, as well as the risk factors, are unclear, because the risk factors, the traditional risk factors and the scoring system, such as the Corona score, they do not function as well in the setting of checkpoint inhibitors. So basically, the goal of the study was to explore early dynamics of systemic CRP levels after initiation of the immune checkpoint inhibitors for prediction of venous thromboembolism in these patients. And why CRP? Because CRP has been shown to be a predictor of poorer outcome or higher baseline CRP, as well as a CRP response. CRP flare has been associated with poor outcomes in these patients, and it's well recognized that they develop a systemic antitumoral immune response associated with a major inflammatory response, in which CRP has been shown to be a major marker. So the methods, so this was a retrospective cohort study of about 405 patients. These were patients with cancer treated in MedUni Vienna. The follow-up was at least for the duration of ICI therapy until subsequent anti-cancer therapy, death, or a maximum of 3 months of the last cycle of the immune checkpoint inhibitor therapy, and the endpoints were VTE that were mostly pulmonary embolism and DVT, but also recorded were splanchnic venous thrombosis, catheter-related thrombosis, and other events. In terms of the CRP dynamics, the CRP was measured at baseline. That is within 4 weeks prior to institution of this therapy. And then it was longitudinally monitored for the first 3 months after the initiation of the therapy. And for the purpose of the study, the CRP dynamics were defined either as CRP flare, which is increase in the CRP by at least 2.5-fold over the baseline, or a CRP response, which was 50% relative decrease from the baseline. So the most important in terms of the cohort demographics is that most of the patients were stage 4 malignancies of a variety of types, mostly therapies or cancers known to respond to immune checkpoint inhibitors. And then many of the patients had received or seen multiple lines of therapies. The median follow-up for the study was about 8.5 months. Defining CRP flare. So among the 405 patients, 70% had a CRP flare, which is again a rise in CRP of greater than 2.5 folds over the baseline. And then in terms of the different definitions, so basically 78 to 80% had the CRP flare, and then about a third had CRP response, which is drop in CRP either after a flare or in about 14% of the patients without a flare to less than 50% of the baseline. And then about a third of the patients did not or were non-responders, which is their CRP did not reduce to 50% of the baseline. And then based on the CRP dynamics, the authors found that the risk of VTE, the cumulative risk of VTE, was about 3.5-fold in patients who had a CRP flare, irrespective of a response or not. More importantly, they also found that the risk of VTE was associated with an increased mortality according to the CRP flare. So the hazard ratio for death after VTE adjusted for cancer type was about 3.5-fold in patients with CRP flare, and then adjusted for the stage of the cancer was 3.21-fold again in patients with a CRP flare. So the conclusions were that the early dynamics of systemic CRP levels are associated with the risk of VTE during immune checkpoint inhibitor therapy, and the highest risk of VTE was observed in patients with early CRP flare after ICI initiation. And then the lowest risk was in patients where the CRP dropped below 50% with no prior flare, but this was a very small proportion of patients, about 12 to 14%. And then they also found a potential link between immune checkpoint inhibitor-induced systemic inflammatory response and risk of VTE, in addition to an independent association of VTE with mortality in patients who have CRP flare. So I think with this, I'll end.
Well, that's great. Thank you all for those great presentations. Thanks so much. If people have questions, please put them in the Q&A or the chat. And while we're waiting for them to come in, perhaps I can start with a few. If Dr. Van Doren is still on, and I know she might have had to go into clinic, looks like she did step off. So George, I have a question for you. In the study with sutimlimab in cold agglutinin disease, you noted that there was an increase in patient-reported outcomes, quality of life improved, despite the fact that these individuals did not require blood transfusions. Could you postulate on why they may have had this improvement in the way they felt without having a need for a blood transfusion?
Thank you, Bob. Such a great question. There's a thought in the hemolytic community in general, both in autoimmune hemolytic anemia and PNH and other disorders where we see hemolysis, that quality of life is affected by the hemolysis independent of hemoglobin as well, in addition to hemoglobin drops and low hemoglobin levels. The idea being that in a chronic hemolytic state, you have an underlying degree of inflammation. At least that's the theory that's being posited, that's contributing perhaps to this fatigue. And the idea being that if we can shut down the hemolysis, or maybe let's say decrease it with agents like sutimlimab, the monoclonal C1s antibody for cold agglutinin disease, or anti-C3, anti-C5 therapies, for example, in PNH, that we can further improve quality of life. And I think this also underscores too that, we focused a lot in the past on these hard outcomes, which are, of course, important, like hemoglobin, but there's an additional component to quality of life beyond that. Now, that is difficult to capture, and I think that the investigators could have done a better job, honestly, with sutimlimab. And in fact, most phase 3 investigations currently looking at quality of life use patient-reported outcomes, which is good, but most of the times they're not validated, externally validated. And the one for surefire way to robustly look at these, although that takes a little bit more money and effort, is to actually measure quality of life directly with direct patient interviews. That's a conversation for another time, but that's a conversation I have had with colleagues in the BMT space and other spaces who want to truly capture the quality of life beyond, let's say, like just a questionnaire, SF12 or whatever it is.
That's great. Thanks, George. I wonder if some of that could be applied to individuals who have non-transfusion dependent thalassemia as well, who have fatigue. That's really fascinating. Yeah.
I think so too.
Anish, I have a question for you, if I may. So the last abstract you presented with CRP and immune checkpoint inhibitors, obviously if we were to intervene with prophylaxis, measuring CRPs would be too late in a sense. So you couldn't measure the CRP and then intervene with anticoagulant because it'd be after the fact. So my question is, are the CRP changes similar from cycle to cycle? So can you use a cycle of CRP and anticipate that in the next cycle of immune checkpoint inhibitors, the change in CRP will be the same?
I think it's a very good question. If the majority of the patients, about 70-80%, had a CRP flare, and these were the group with irrespective of whether they had a response, they halved their CRP. Irrespective of that, they were at high risk for events. And so, although it's a very interesting observation, and this question it's coming up more and more. It's again, 80% of the patients who are at risk, and so it's again a major. I think this whole CRP as a marker of inflammatory response, as a marker for VTE in these patients in this group will have to be refined a little more, just because they're just 80%, 85% of the patients they're claiming are at high risk, which does not really help us that much.
Okay.
I didn't answer your question directly, but that's what came to my mind. And like, again, yes, it's interesting, but it's, you're telling me that most of the patients are at high risk. So,
Yeah. So there was a question that came in the chat, the question and answer, extending this. And the question was, are there recommendations to do CRP levels prior to immunotherapy and then monitor them on a monthly basis? And is there any role at this point for prophylaxis? And the individual asked about aspirin.
I think this was a question that was asked at the meeting as well, and there are none. And I'm not sure that what the European practice is, but I don't think that it's been, done. It's such a non-specific, test among everything else that has been happening and being done. And I'm not sure that it's being routinely done. The question of prophylaxis, I think that there are it's hypothesis generating, and I wonder if it's if these group of patients should be separately sort of included in all the prophylaxis trials that are being undertaken, and perhaps a more correlation, those types of studies be done, including CRP and other markers.
Yeah, this is fascinating. A lot of area for research for sure. George, I had a question for you as well. In your study in the study you reviewed where splenectomy was performed for immune cytopenias, you noted that I think in about 20% of the patients, a new diagnosis was made. So an additional diagnosis as presumably potentially a cause for the immune cytopenia. And I'm wondering if what the dates of the study were done. And in particular, I'm thinking that with modern techniques of flow cytometry and molecular studies on the peripheral blood, would we still expect to see that high rate of an additional diagnosis made before a splenectomy is done?
That's such a good question, Bob. This abstract, I think, caught a lot of people off guard, especially because, and of course, all of these are orals, but especially because this was a retrospective analysis. So you usually don't expect such a hard-hitting component because, again, these are consecutively treated patients with splenectomy. The years were 2000 to 2020. The median follow-up they did not report on, but as I was in touch with the investigators, they noted that they're tabulating it as they're putting together their manuscript now, because I was curious, how many years since. Also, what was not reported and what they're looking at, and a question I had asked was, are these diagnostic changes? And they were, I should just clarify too, that investigators are calling them changes. So not only the fact was that initial indication, they're calling the initial indication as incorrect, meaning that the entire diagnosis was switched to the postoperative diagnosis as opposed to being added on, which is interesting. And so when I asked about whether this was time variant or not, meaning that, like, let's say in the 2000 to 2005 period, is that where we're catching all of those 20%, or is it mostly kind of the same across the board? They weren't able to answer that question, only to say that it appeared that there is not like a huge spike in the early data, although it might be a little bit less moving forward. It seems like, and we'll see what the manuscript shows, I won't speculate beyond that, but it seems like these misdiagnoses may still be happening. And again, I mean, the Cleveland Clinic is a fantastic health system. And so if this is indeed accurate, and if this is what they ultimately end up reporting, I think this is something that we all have to pay attention to, because if this is happening in the Cleveland Clinic, then I don't think we're immune to that either here at Yale or anywhere else.
Yeah, that's really fascinating, George. So diseases that are really, truly isolated to the spleen, at least by our current techniques to discover them in the blood. Yeah, that is fascinating. And Anish, if I may, your catheter, so another So another question came in. This is for you, Anish. So many factors affect the CRP level. And how do you know the CRP elevation is due to the immune checkpoint inhibitor or infection that developed afterwards, perhaps?
Yeah, it's a very good question. I mean, it's just such a non-specific marker, but there's something about it because it's a significant rise, and it's although it's a retrospectively done study, but it's a cohort, and there is clearly a pattern that has been previously recognized as well. So one of the citations that had looked into CRP, I don't know how well they can adjust for other things. I mean, these are patients with systemic metastatic malignancies, and but even previously when they had reported CRP flare and mortality or poor outcomes, it was a similar kind of dynamic. So it had been recognized, and so it's a good question, but it's such a non-specific marker.
Got it. Okay, thank you. And George, if we can go back to you for a minute, the Efgartigimod trial, fascinating drug. And I assume that there's a potential that this could be used in any autoimmune disease where IgG is felt to be the culprit. Is that how you're thinking about this as well?
Well, I'll say that's how the pharmaceutical company is thinking about it.
Okay,
I'll say
fair
that for
enough.
sure because I've had a conversation with them. Yeah, so it was approved. This drug was approved for myasthenia gravis just last year. They're looking at it, and they have, obviously, as I presented, have looked at it in ITP, but I know that they're really excited about the whole host of neuro autoimmune disorders that are out there. And if it works and if it's successful, you can make an argument that this kind of mechanism could then theoretically help with any disease that has this pathologic autoantibody component, or at least it's worth testing in any disease like that. Especially if they ultimately go on to prove that the safety profile is what they claim it to be, because as we've seen with other drugs, even phase 2 or phase 3 studies sometimes are not enough, right? We need post-marketing surveillance, phase 4 studies to really see an effect across rare diseases. Presumably, they're going to be looking at a lot of rare diseases, this autoimmune neurological space. So yeah, I think there's a good amount of excitement with it. I'm curious to see what happens going forward, but I do expect that we're going to see a dozen plus trials within the next 10 years in a bunch of autoimmune mediated disorders with this mechanism.
And then presumably, since B cells and plasma cells are not being affected directly, the immunosuppression will be less than with a drug that causes apoptosis or death of B cells. Presumably.
That's a really good point. One that I hadn't actually discussed with a pharmaceutical company, but one that makes a lot of sense to me.
Yeah. The data will tell us, I think.
I think so too.
Yeah.
It would be nice, right? Often we're hoped that this is going to be like the next big thing. Hopefully that ends up actually being the case here. We'll see.
Okay. Dr. Sharda, a question about the catheter study, if I may.
Sure.
So I noted that in the catheter 3 study, the authors used a low molecular weight heparin for a week and then transitioned to a DOAC, apixaban in the case of that study. Do you think that's necessary? It seems like that's excessive treatment, quote, excessive, compared to how we treated DVT.
Yeah, I was also surprised to see that, but I think that to increase their recruitment, they did that. I think most of us have a bias to, I know many people tell me, like, you want your patient to cool off, like with a heparin, and then, do something. But it's strange, this is something that someone would do with, say, dabigatran, because that's what the originally studies were kind of designed. But I think this was also to increase the recruitment. And so they allowed like 7 days and they made a protocol. I mean, everyone's treated, but 7 days of dalteparin, low molecular weight heparin, followed by apixaban. Whereas they didn't do it for rivaroxaban.
Okay. And so you don't think the issue was people had cancer, therefore they might need a heparin-like drug before they get switched to a DOAC?
No, I think this was done rather quickly, and this was done after edoxaban and others already. I guess the data was already out there. So
okay. Great.
I think
Great.
the interesting thing was, and this often comes up, which is what to do with the line.
Yes.
I liked the fact that these were real, like, symptomatic proximal events. I mean, 3/4 of them had subclavian involves. Actually, many had pulmonary embolisms too, and they were able to save, like, line. If you combine, especially the warfarin trial is from 2003, 4, something like that. I think it was published in 2006. But at least if you combine the rivaroxaban and the apixaban, you can see that, the lines can be saved without really recurrence or symptoms or post-traumatic syndrome, and can be used very safely. So that's, I think, is pretty good data to have.
Okay. All right. Just one follow-up question to you, and then we'll end. And there may not be data here, but so if you had a patient who had a symptomatic line-associated thrombus in cancer, would you start at all with a low molecular weight heparin, or would you just begin with a DOAC, a apixaban, let's say?
I would just begin with a DOAC. I mean, I was following
Okay.
the rivaroxaban thing as it
Yeah.
is, and now
Okay.
we're using them, kind of interchangeably.
Yeah. Okay.
So I definitely would just, begin them.
Great. Okay. Thank you. Well, the hour is almost up, and I'd like to thank our speakers. These were really great abstracts you chose to present, and some of them are clearly going to be practice changing, I think, for all of us, and we're all excited about seeing these new drugs in development and new ideas brought forth. So thank you both very much, and thank you to the participants who are here. We really enjoyed having you, and I hope everyone has a nice rest of the day and weekend. Bye-bye now.